Welcome to the JRPal podcast. This is Eric Widera.
This is Alex Smith.
And Alex, somebody else is in our room with us.
We have another host with us today who's been a frequent host and guest on this program. This is Ann Kelly, who's a social worker here on our palliative care service. Welcome
Hi, guys.
back.
Happy to be here.
And Alex, who is on Skype with us?
We have a dear friend from the other side of the country, University of Vermont. This is Bob Gramling, who is the Holly and Bob Miller Chair of Palliative Medicine at the University of Vermont. Palliative care physician, ethicist, really smart guy, outdoorsy guy. Welcome to the Jerry Pal podcast, Bob.
He was a smart dresser too, Alex. You were saying, right? We get that in.
This is on YouTube, so you can go to the JRPal YouTube channel and see Bob's smart dressing.
Midway through, Bob may pull out a sword and do a martial arts demonstration.
But we're not here to talk about martial arts. We're here to talk about Bob's paper in Journal of Pain and Symptom Management titled Palliative Care Clinician Overestimation of Survival in Advanced Cancer Disparities in Association with End-of-Life Care.
What? We are perfect prognosticators.
We are.
No, there's no way.
Well, let's
I'm
pause.
perfect.
Let's pause. We'll talk about that. But before we start going into this JPSM paper, Bob, do you want to give Alex a song he can lead us in with?
Ooh, Alex, I was thinking maybe Big Yellow Taxi by Joni Mitchell. World leads in a little bit more Joni right about now.
Yeah. Is that why you chose that song?
That is, absolutely.
All right, here we go. Start over. Hold on. My phone turned off. Hold on. That's unusual. Can you turn down Bob's Skype because there's so much background? Is that possible?
No.
No. Okay.
Nice try.
Yeah.
Do you want me to mute it?
Yeah, try that.
Yeah, mute it during the song. Yeah. They paved paradise, put up a parking lot with a pink hotel, boutique, and a swinging hot spot. Don't it always seem to go that you don't know what you've got till it's gone? They paved paradise, put up a parking lot. They paved paradise, put up a parking lot. They paved paradise, put up a parking lot.
Isn't there like an ooh bop bop?
Yeah, that was your part. You're
supposed to do ooh bop bop?
Ooh, bop, bop.
At the end of the episode, Eric, go
Yeah,
have another
I'm
opportunity.
at the end.
Put me in, coach. I'm ready.
Thank you, Alex. That was beautiful.
Thanks, Bob. Good request.
So let's talk about this article. So prognostication and whether or not palliative care providers are any better than the past studies that show we're not very good at prognostication. But before we do that, how did you get interested in this as a subject?
I think most of my career, I've been fascinated by concepts of predicting the future. And before I was palliative care researcher, I did a lot with risk communication and predicting the onset or the risk for serious illnesses. So I think this concept of uncertainty, I love the philosophy of what prediction might mean, the future that has not happened yet, and how that impacts our well-being, our perceptions of self, and our decisions in the context that we are in our medical world. So I've been kind of pulling this string for a while since probably the late 90s, early 2000s in different contexts, and I just find it super fun.
Yeah. So, and clinically speaking, this is such an important question, right? Because so many of our patients' decisions, right, hinge on prognosis, right, near the end of life, right? And we've done some work about prognosis and prognosis communication further out in the order of years and decades. But the kind of prognosis you're interested in here is relevant to both geriatricians and palliative medicine providers, probably even more the palliative medicine providers, although both, and maybe even primary care docs too. Sorry, that wasn't a question.
It was, the problem with getting a bunch of palliative care people in the room, we can all tolerate silence. For long periods.
That's right.
I was waiting for Alex to finish it off with a question.
Yeah.
I'm just
Tell me more, Alex.
So, yeah. Who does a study like this appeal to? I guess is a question.
So for the audience for the paper or the implications. So
yeah.
Well, I think from the audience, they're for those who might be trying to help us scale palliative care services to larger contexts. One of the things I'm interested in, not just with prognostication specifically, but understanding what maybe some of the active ingredients about what we do, and despite the fact that we have a fair amount of observations in the literature about the frequency of overestimation, there really wasn't too much out there about the empirical implications of that, or at least the association with what decisions may unfold and what end of life might look like. So this paper, one of the things we were hoping to do is to identify whether there was any potential link between how frequently we overestimated someone's survival and the end of life course they might experience,
right,
manifest primarily by whether they enrolled in hospice or not, is one of the features we were able to measure.
Great. And before we get to the study, which is another setup question, in general, outside of palliative medicine, how good are doctors or other health professionals at prognostication?
Well, I think in defining good, if we separate out, estimating what we would expect the future to look like, then how will we communicate it? I'll stick just on the estimating piece for cleanliness of that answer, and I think we typically as human beings err on the more optimistic side, and that's what most of the literature around this in this field would suggest, although not always.
Right. My recollection is Nicholas Christakis did a systematic review of, physicians' estimates of prognosis and actual survival, and physicians tended to overestimate prognosis by as much as a factor of 5. And oddly, the longer that patients
we're a pretty optimistic bunch. We don't like thinking of this mortality thing.
Yeah, but not palliative care docs, right? Because we've been trained.
Oh, we are
experts in the
people,
field.
Alex.
Right, Anne, you work with palliative care docs.
You guys are always right.
Wow.
Is that how I keep my job here?
Gosh, that's quite a burden if that was true.
What's the old saying? Prediction is really difficult, especially about the future, or something
Absolutely.
like that.
That was Niels Bohr, wasn't it?
Niels Bohr. Everybody says Yogi Berra. Yeah, but Niels Bohr.
Yeah, Yogi Berra gets credit for every smart saying out there.
That's right. It's getting earlier or later out there.
So I'd love to talk a little bit about what you did in this article and what you found, but maybe then also afterwards talk a little bit about this issue of uncertainty and how we deal with it in our field and how we should think about it. So let's set up the article real kind of quickly, like in a nutshell. How did you set up this article? What did you do to figure out our palliative care providers? Are they any good at this?
So the piece, the study is a cohort study where it's not an intervention to the extent that any research is not an intervention. We're observing what naturally happens in palliative care consultations, and this was at 2 medical centers, one that you're very close to at the moment and one that I'm somewhat close to at the moment. And we're trying to ask the question fundamentally is what is a good conversation, and that's a large, challenging question. But in order to do so, we both observed and recorded the conversations with the palliative care team and patients who had advanced cancer who were referred for consultation. Before the consultation, had a brief interview with patients. After the consultation, had a brief interview with patients, at least the following day. And I mean brief, I mean 20 questions. We really wanted to try to not over-select for people who had more energy and more time. We wanted to get as best a sampling as we could of the people we see in a palliative care service. And immediately after the clinician exited the room, one of our research observers asked 3 questions, one of which was this prognosis question, the estimation of survival. And we asked them under the assumption that we're commonly faced with hospice decision making. If we assume a natural course of disease, what is the most likely time interval you expect this person to live? And the intervals we chose were the ones that at the sites were relatively commonly asked of us, so that wasn't a foreign concept. For example, less than 24 hours, less than 2 weeks, less than 3 months, less than 6 months, or longer than 6 months, because those thresholds are often useful for our colleagues in case management and social work to think about what might be some potential locations for receiving hospice type care beyond whether they were eligible prognostically. So that's how we chose these windows, because they had a familiar clinical feel to them. We did pilot test the idea of doing the surprise question or some version of the surprise question, but in our beta testing of that, it was palliative care physicians aren't surprised by much. So it didn't lead to much distinction, and it was not a very useful measure for that reason. So we asked people to put their nickel down on these time intervals, and then we watched how long people lived, and so we defined accuracy based on whether people died during the interval selected, overestimation if they died sooner, and underestimation if they died after.
Now, did you think, for me, there is a difference between whether or not they survived, 0 to 2 weeks or, 2 to 4 weeks versus I thought they had, days or weeks and then they're still alive 6 months later. Did you look at it, kind of that issue? It's not were they a little bit off, but were they really off?
Yeah, the magnitude of error.
Yeah.
I can't pull it up right now, but I am happy to if your blog post posts some follow up, I can give you the percentages and how far off people were. Most of the time it was 1, maybe 2 categories off. But the problem is, in this measure, the categories get wider, so you have a much wider opportunity for accuracy the longer out you go.
Yeah. So
magnitude gets a little hard to judge in a precise sort of way.
Mm-hmm. And how many clinicians did you have overall in your estimate?
Well, we had 54 clinicians. In these, I'm looking at the table here. I'm going to move the paper here so it doesn't make sounds.
Let me ask that again. How many clinicians did you have, and how many patients did you have in your study?
So in the study, we had 113 clinicians, about half of which were learners rotating with us, but we had 54 palliative care clinicians, broken down between the most common discipline was attending physician, followed by fellow physician, and then nurse practitioner, and then nurse, chaplain, social worker. And we had 240 patients, 231 of which had a estimate of survival by the clinician. 9 that didn't were either died or were discharged prior to the consultation happening.
All right. So, what did you find in this article? What were the results?
We found that palliative care clinicians were really good at distinguishing who's going to live longer and who's going to die sooner relative to one another. And actually a quite striking pattern. It's rare to see how well people can predict in a stratified way. What we did find is in every category, we overestimated. And I say we because I was one of the clinicians in the study.
So, I was just looking at this figure here, which we can maybe put on our blog post. Survival time by clinician estimates of survival. This is a Kaplan-Meier figure. And, it looks like in general, as you say, the palliative care clinicians were pretty good at stratifying. There's no inversions here where, they predicted shorter time on average and people in one group and then a longer group. There's no funny things going on. There's like a clear relationship between predictions and survival. But and it does look overall, like if I look at the 50th percentile for each group, it looks like the less than 24 hours group, there were only a couple patients there. They were accurate, 100% accurate. 24 hours to 2 weeks, looks like that lands pretty much on the nose. And then the next one is 2 weeks to 3 months. Looks like that one lands at about 30 days, which is which is within that 2 week to 3 month. And then the 3 to 6 month looks like that one lands at about 50 days, which is that one lands at 50 days. So that one, how does that make sense? If that one lands at 50 days, how is that an overestimation?
Well, so what you're looking at is the median within the curve. So within each group who has estimated, that whole category, anything beyond the range of the question is going to be considered an overestimate. So I'm not sure I follow your question, Alex, about how the median impacts that overall categorization of overestimate. What do you mean by that?
So I guess the question is that if the median survival for each of these categories is around where we expect it to be, how are we categorizing overestimation? And is it because the median isn't the message? It's that 50% of people who are kind of potentially surviving longer than that, and that 25% are surviving a lot longer or fighting shorter than that.
Got it. So yeah, half of the time we're right, I guess, is probably one of the simplest ways of getting at that. So if you looked at all participants, the clinicians were accurate. I think it was between. Let me look at the actual number here before I misquote you on the air, or misquote the study on the air. Can you give me 1 second?
Yep. We'll take a pause.
I want to make sure.
And maybe I'll ask that question again. It's such an awkward question.
Yeah, maybe
Do over.
Redo.
I am.
Maybe
Good.
instead of asking that, hold on. I'm going to ask you about table 2.
Okay.
Because that's going to be a lot easier question. Okay.
Yeah, because you can't really understand what Alex is.
Yeah.
Like we're talking about a graph.
Right. It's right, and the listeners can't interpret the graph because they don't have it in front of them.
I am going to table 2, and I'll just quickly also answer that it was more than 40% of the time that we were right. So that So the accuracy was accurate.
Let me set that up with a question. I'll ask you how often we were. So Bob, how often overall were the clinicians right?
Alex, it was about a little over 4 in 10.
A little over 4 in 10. So
that means 6 in 10 times we're wrong?
6 in 10 times are wrong.
That does not sound good. I mean, that sounds like we make a lot of errors. And you're saying most of those times we're making errors, we're overestimating the prognosis, right? This is not underestimating of prognosis.
Yeah, we're about of the errors we make, we're about 8 times more likely to overestimate than to underestimate.
Overestimate than
in this study.
In this study, and we were and do we do better at shorter term prognosis or longer term prognosis?
Let me take a look, so I get your numbers correct. So we get better at the challenge of answering the question. Why I wanted to look at the specific categories, Alex, is that we're better earlier at estimating survival. The problem is our last category, the longest category, is just greater than 6 months. So the call is a little bit easier there on how long someone might live, and so the accuracy. The overestimate does increase up until the 3-month category, but then it dips down again because we have such a large window that we're looking at.
Yeah, so I'm looking at this table too, and in the observed accuracy by clinician estimate, among those where the clinician survival estimate was 3 months to fewer than 6 months, or 81 patients in that group, 58 of them, or 72%, were overestimates. 52% ended up being overestimates. The patient lived less than 3 months when the clinicians thought they were going to live 3 to 6 months. That's the group where we did the worst by far. So what I guess what that raises for me is, what is the clinic when you were making these groups? What's the clinical decision that comes up at sort of like that, 3 to 6 months versus less than 3 months boundary?
So oftentimes it's depending on your healthcare environment, it tends to be eligibility for acute inpatient hospice care versus relatively subacute inpatient hospice care. Where I practiced during this study, we would have comfort care homes, is what we referred to them as, that they're 2-bed philanthropically given homes, and there were 28 of them that could accept patients with hospice care, typically shooting for a window of survival of under 3 months was the population that they were trying to serve. In the acute hospice setting for symptoms requiring inpatient and survival of less than 2 weeks, people would access some of the inpatient hospice units in the city more easily. So that 2 week to 3 month had an implication for what was potentially going to be offered for that person as a place to receive hospice services if home was not a viable option.
And were there enough subjects in the study to see, did prognostication depend at all based on if you were a fellow, or if you're a physician, or if you're a nurse practitioner? Did it vary at all, or could you even look at that?
Yeah, so we have that in Table 1. If you're turning to that, it has the frequency of overestimation, and that is also due to the number of estimates each group made. So it wasn't that each person made the same amount of estimates, which makes this a little bit hard to compare apples and apples. However, we did find that the attending physicians were the least likely to overestimate, followed by the fellows, and then followed by the nurse practitioners.
And when you were asking them to offer an estimated prognosis, was there any questioning around what information they were using to come up with their estimate, or how their estimates were informed?
No, they were never asked to justify why. Sometimes if you had a learner rotating with you, sometimes this question generated some conversation, and I know our research observers would sometimes see a collaborative discussion about this, thinking about what might be the factors going into this judgment. But we weren't asking them to write that down or to give us an exact sense of that.
And they were asked after the consultation happened, not the first day of consult, but when the consult discontinued, or when exactly were they asked?
These were all of the conversations that were recorded within the first day, or they were the initial touch with the patient, and we had up to 3 visits to get what might be considered the initial consultation with them. For example, the person you went to say hi, but then they were being taken down to radiation, that didn't count. And so these estimates were done after really the first assessment of the person when you met them.
So that's an important consideration, because I'm not perfect the first time I see them, but by the time of my last
By
visit,
the second time, Alex is perfect.
Oh, boy.
But you do wonder, right? Because in that first visit, you're just getting this one-time snapshot. Mm-hmm. If you have 2 visits, then you can see somewhat of something of a trajectory. You get 3, 4, 5 visits, and then you're really seeing, it's like a time-limited trial. How are things going? Are they going in this direction or that direction? Is function getting better or worse? Is delirium resolving, not resolving?
Or is it the longer we get to know someone, the worse we get?
Yeah, could be. That would be an interesting follow-up study.
And then there's the argument that if our prognostication got better, or at least our prognosis estimates got better, then we we might be underestimating the potential relationship between error and hospice use, for example, as an outcome. Because if this self-corrected over the coming days, it would actually mitigate some of the potential causal relationship with the outcome.
And tell us a little bit more about this outcome. So what did you find around hospice use?
That people whose survival was overestimated by the clinician had about between 2 and 2.5 times less likely to enroll in hospice before they died, and about a similar estimate for enrolling in hospice for at least 72 hours before they died.
So this had potentially real clinical significance.
Potentially, absolutely.
Yeah, if it's causal. Well, did you get any assessment of the patient's estimates or their loved ones' estimates of how long they might have to live?
It's not presented in the paper, but yes, and it doesn't have a large effect.
A large effect on hospice use.
On the estimate, it doesn't change. It's not a confounder. It doesn't function as a confounder in this association.
Okay, interesting.
We do have a separate paper coming out about the potential factors influencing overestimation, and patient perceptions of their prognosis do have a potential impact there, as do personality types. Optimistic personality types do appear to be related to overestimation.
To physician overestimation.
Yeah, it's fascinating. The contagion of optimism is a little bit of what we're looking at.
Oh, that is fascinating. So physicians tend to be swayed by the patient's perception of prognosis and how optimistic the patient is about their future.
That's what our association would suggest. Yeah.
So I got another question. Yeah, thinking about this and thinking about how when I see patients in the hospital, and if I was asked to give a prognosis to somebody, I can give a prognosis, but I also have varying degrees of certainty, my confidence around that prognosis. So in some patients, I may say, oh yeah, we're looking at, it's going to be 0 to 2 weeks, but my confidence level is low. Or in other patients, yeah, they're going to die in the next 2 weeks, and my confidence level will be very high. So is that a potential flaw in this, is that we haven't really assessed how confident are these clinicians in making these decisions, and does that vary as far as how good they are? And I just like also, I think there is some data that around prognostication outside of our field, the more confident we are in our prognosis, the worse it is. So it may not be. What are your thoughts on that?
The trajectory of expertise as confidence continues to rise and accuracy tends to fall?
Yeah.
Well, I mean, I guess the first step is that at least just to acknowledge here, now this is talking about estimation. It's not talking about communication. But if we follow that through with having a conversation with someone about how long we expect they might live, I just want to acknowledge for some people that's irrelevant information. If it's not going to inform any of their decision making, if they don't have prognosis sensitive preferences, then it may just be toxic information. And for some people, the bounds of uncertainty that might bother us are extraordinarily useful for their decision making. So I think that what I find fascinating is that finding an association for me does suggest the potential that our judgments do relate to how our conversations or the options that patients are presented may unfold in their end of life course. But I don't think it necessarily informs how and when we need to communicate prognosis and how we do that. For example, I could be off by a category, but by the way that I'm talking about it, it may be sufficient for that human being to make the choices they need to make. Is that getting a little bit at what you're suggesting, Eric? Or?
Yeah, I mean, I think this is the reason I'm fascinated by this subject about prognostication and uncertainty. There's so many different layers, and even when we break prognostication apart, there's this initial estimation, then there's the communication about prognosis, and then there's the patient and family's interpretation of that prognosis. And I think the data would suggest that optimism on top of optimism on top of optimism bias for each one of those particular steps.
Agreed.
Yeah. So you also looked at differences between prognoses for minority patients versus white patients. What did you find there?
That for people who self-identified as Black or Latino had a substantially higher risk of overestimation from their clinician, to the order of 3 to 4.
Wow. So clinicians are more likely to overestimate. Palliative care clinicians are more likely to overestimate for Black and Latino patients compared to white patients.
Yeah, in our study.
Why do you think that is?
Man, I wish I knew. I mean, the one of the things we didn't have, one of the weaknesses of this study is that we weren't able to look at concordant or discordant racially apparent pairs, meaning our clinicians were all white and self-identified as such. And so one of the questions in the related work with how appearance may influence judgments is that might be bilateral. So we can't ask the question about whether the same phenomena existed for clinicians who may share a similar potential identity based on appearance. But what I do wonder a little bit about is if you know what, I guess I have to plead ignorance, Eric. I think that we've thought a lot about this, about why we think this might be, and I don't have sufficient data or the types of questions in the study to be able to inform any of those guesses I might throw out there.
So there's a lot of uncertainty.
Yeah.
The differences we've seen. What's that?
I said, so there's a lot of uncertainty.
Well, I mean, but it is. But one of the things that's intriguing to me is the question. I mean, we do know that the end-of-life course for people who self-identify as Black or Latino often looks different, and whether that's a disparity or whether that's a difference is certainly something that we haven't had enough scientific clarity all the time. But I think this adds to the fact that if the judgments are wrong, it's more likely to lead to disparities than differences that are warranted based on preferences.
So is there anything else that you want to, what's the takeaway for practicing palliative care clinicians out there? Like, should you just take your estimate and, I don't know.
Divide it by 2?
Right. Divide it by something.
I think that, I mean, with most of what we...
Wait, hold on. You're breaking up here. We're going to ask you that.
Carry humility well in what we're doing.
Wait. I'm going to... maybe we'll just... should I ask you again?
Mm-hmm.
Yeah.
Yeah, are you hearing me?
Yeah, you were breaking up. Let's try it again. So hopefully,
my last answer was perfect.
Good. So what's the take-home message for practicing clinicians out there? Should we take our prognostic estimates and cut them in half or cut them by some fudge factor?
Well, I think probably the biggest thing for us is to just, I mean, I think we do this anyway, and I think we're reminded of all the time, but bring the humility to these estimations and know that where we're affected culturally by similar factors that we've observed elsewhere. And this study itself for me is I'm more likely now to check my estimations more carefully with calculators such as your ePrognosis. Thank you very much. And also with other colleagues saying, am I nuts? Am I seeing something here that you're not seeing? And I find that to be helpful for me. And I don't feel, because these errors are not symmetric, meaning for some people an overestimation may not be a problem for them. For some, it may be a big problem. And so I'm also thinking about the human being for whom this relates. Is an error in this direction going to lead to greater regret than an error in this direction, and try to bring that into how I de-bias my thinking.
Yeah, I often find it helpful. Like if I give an estimate of prognosis and Anne looks at me, kind of cocks her head with a confused look in her eyes, I know I probably just messed up. And, the couple of times where we've actually tested this by each of us putting our nickel down on prognosis, I think you got them much closer to right than both me and Alex. Would you agree, Alex?
Agree.
I noticed that it's sort of funny. I think that's sort of one of the things I was curious about around what goes into people forming these estimations. And I can imagine that people coming from different vantage points might be using sometimes very often similar information, but also different
information. Yeah.
Yeah. I'm wondering for all three of you as medical providers, when you hear results like these, does it make you feel wary to offer estimated prognosis, or how does it contribute to your thinking around delivering this kind of information to patients and families?
Well, I'll take a stab at that. It doesn't dissuade me. I try to be humble in how I present it, but I also know culturally this is the information that people avoid so much, that this is the elephant in the room, and that elephant can be a heck of a lot scarier if you're not talking about it. So I'll oftentimes start this thing. I'm just noticing that a lot of people are having a hard time thinking a little bit about how long your body might live with this. Is that important to you? Is that something that you really want us to try to turn towards a little bit more? And some people say, nope, I'm fine, day to day, and you're doing your best. Totally get it. And some will say, yeah, it really kind of matters. I want to make it to for this. And so I find myself comfortable to talk about it and acknowledge that I'm doing my darndest to be accurate, but you know what? We're learning that we're not so great at it as well.
Mm-hmm. And maybe as doctors, we're not so great at it because we tend to focus on medical sorts of things. And palliative care clinicians, we tend to think, oh, we're better than, the primary medical team, the ICU team who's focusing on, the sodium, the potassium. We're seeing the patient. But maybe we're still influenced by some of those factors, too, in ways that social workers aren't. Or I remember, a previous social worker used to be very good at estimating prognosis on patients as well. And then there's this story out of Brown, right, about the cat. Right? On the hospice unit.
The hospice cat?
Yeah, the hospice cat who would go and sit on the beds of patients who were dying. Just had some sort of sense, right, about the patients who were dying. I think they were going to turn that into a book.
Yeah, I'm pretty sure that's observation bias. Like, oh, look, the cat's with this person who's dying, but the cat's with everybody. We have a cat in our CLC, kind of the same thing, but the cat goes into everybody's room. But you only notice when the cat's in with the dying patient.
No, I think there's something there.
No.
We need to do another study on the cat.
But I think for me, the key is that there's so much more to learn. It helps me right my ship a little bit, but it doesn't change my overall direction. But I also have to think about all of these other things that we can learn from other fields about risk and uncertainty and prediction. How can we bring that into medicine, back into medicine, like we used to actually hold this as like one of the most important parts of being a doctor is prognosis, and we've kind of lost that. How do we bring that back into the fold? And even like learning from other fields that maybe having one person estimate prognosis, like you're okay. Like we're still pretty good at estimating prognosis. Like there's some difference in like weeks or months, but pretty much most people got weeks to months right. But what if they combined different members of the team and we kind of combined those estimates together? Would it be any better? Mm-hmm. What if we included other things like family members in overestimation? And then that's just like the first part of prognostication. And then like there's the communication part. Like how do we deal with that? And I loved your statement of toxicity or information toxicity when we give too much information. Like that one JAMA study of chronically critically ill patients where everybody got prognosis no matter what they wanted or not, and there was higher rates of PTSD in those folks. So just it's so complex.
There's also the introspection of to what extent do people's perceptions of their own survival time, how frequently is that independently predictive? And I find that quite fascinating because there is a related literature that suggests that it is in ways that we can't explain. So we may not want to rest too much on predictions that might seem really discordant with ours, but I find that somewhat interesting as well about what people believe is going to happen in their bodies.
Great. Anything else you want to talk about, Bob, with us?
I'm appreciative of you taking the time and that you're interested in the topic, and I just you took a time to talk with me today, and I really appreciate it.
No,
It was
I
nice meeting you, and I know these other fellows, but it was really nice to meet you.
And you, thank you.
Yeah, I always think about like weather prediction. Just because sometimes we're off with weather prediction doesn't mean that we should stop predicting the weather. Just means we need to get better at it.
You know what? You know what we have a student doing right now? I just mentioned that as part of our related research is in natural language processing and machine learning, because we're working on trying to automatically identify conversation features to be able to scale up a lot of these studies of communication. Having them right now pull up all of the forecasts from the National Oceanographic and Atmospheric Association to use that as a training data set to be able to identify what is some of the uncertainty language that's typically used in weather forecasting that might be a way of being a training data set for how that functions in our types of conversations. So it's funny you should say weather, but there's a lot of similarity in the words that show up in those things, which is interesting.
That's fascinating.
Alex, do you want to end us off with a little bit more?
Thank you, Bob. Appreciate you taking the time. This was great.
My pleasure. Thank you, everybody.
Late last night, heard the screen door slam, and a big yellow taxi took away my old man. Don't it always seem to go that you don't know what you've got till it's gone? They paved paradise, put up a parking lot. They paved paradise, put up a parking lot. They paved paradise, put up a parking lot. They paved paradise, put up a parking lot.
Ooh, bop,
Feel
bop.
the burn.
I was waiting for the ooh, bop, bop, bop. Didn't happen.
Bob, thank you very much. Thank you to all of our listeners this week. We look forward to having you listen to our podcast next week.
And if you're viewing this on iTunes or any other app, please rate us, give us a thumbs up, or don't rate us.
There's no
Thumbs
middle
up or
ground.
nothing.
Goodbye, everybody.
Bye.